Good afternoon. I wanted to welcome the Justice and Mental Health Collaboration Program and Second Chance Act grantees to a webinar on screening assessment of co-occurring substance use and mental disorders in the criminal justice system. We're pleased to have a national expert here to speak with you and discuss screening and assessment tools. Dr. Roger Peters is a professor in the Department of Mental Health Law and Policy at the Louis de la Parte, Florida Mental Health Institute at University of South Florida, where he has served on faculty since 1986. Dr. Peters has served as principal investigator and director for several grant projects, including a NIDA Research Core Center on Co-occurring Disorders, Justice, and Multidisciplinary Research. He currently serves as the Florida Supreme Court's Task Force for Mental Health and Substance Abuse Issues in the Courts and is a faculty member of the National Judicial College. Dr. Peters also serves on the editorial boards for the Drug Court Review, the Journal of Dual Diagnosis, and the Psychiatric Rehabilitation Journal. Dr. Peters served as chair and co-editor of the SAMHSA CSAT Treatment Improvement Protocol, or the TIP number 44, on substance abuse treatment for adults in the criminal justice system. He also is the lead author of the monograph, Screening and Assessment of Co-occurring Disorders in the Justice System, which will be published in March 2016 by SAMHSA and the National Gain Center. Wanted to additionally let you know that he has offered to make the slides available, so we will be sending an email after the webinar in order to distribute the PowerPoint slides to the participants of the webinar. If you have questions and answers that come up as Dr. Peters is speaking, please use the chat box on your right for the questions and answers, and I will be able to aggregate those questions, and then we will leave about a half hour for questions, answers, and discussion. So with that, I'll turn it over to Dr. Peters.
Great, and thank you, Sarah, for the nice introduction. And I'd like to thank the Council of State Governments also for hosting this webinar today. And thanks to all of you for joining us in the webinar. So we have three goals that I'd like to share with you today. First, we're going to review the importance of screening and assessment of co-occurring disorders in the justice system. I'd also like to have us identify evidence-based instruments for screening and assessment of co-occurring disorders. And we'll point to some examples in mental health, substance abuse, trauma, and other areas as we proceed today. And then finally, we want to explore several key issues in providing screening and assessment with offender populations. So that's just a brief overview of where we're going today. And I will move directly to just an overview of some of the rates of the disorders in the justice system. And I'm probably preaching to the choir here, but as you know, the rates of the disorders are much higher among offender populations than they are in the general population. You can see to the left-hand side, rates of mental disorders are about 5% in the general population, but in jails and prisons, you can see the rates are really much higher, about 4 to 8 times the rate as in the general population. So we have a more pronounced representation of these disorders among women, if you see, in the green bars versus men, but overall quite high rates compared to the general population. Women have higher rates of trauma and depressive disorders, men slightly higher rates of psychotic disorders, but there are differences. And as you can see between jail and prison populations in this example, they're about the same rates of the disorders. And if you look, actually, incidentally, if you look at the number of prior incarcerations among offenders, you'll find higher rates of the disorders as well. So moving on, just looking at the specific disorders in the next slide, you'll see that the most common disorders that we find are depressive disorders, followed by bipolar disorders. You have the psychotic disorders down below. One set of disorders that we'll talk more about that's, I think, underrepresented here and is a really low estimate is the post-traumatic stress disorder, the trauma history, PTSD disorders here, which is 7% listed on this chart. But if you look more carefully diagnostically, you'll find much higher rates, and we'll talk more about that. So for people with mental disorders, what are the rates of substance use disorders in offender populations? Well, I think as you know, again, the rates are, again, augmented compared to the general population. And so if you see the rates here for offenders that either don't have identified mental health problems or have an identified mental health problem, which would be on the left side of the graph there, you'll see the rates are highly augmented among those that have a mental disorder. And you have a cumulative rate of about 74% of substance use disorders among people who have a mental disorder in the justice system. So if we look at people that have a mental disorder in jails, prisons, community correction settings, courts, really, I think the bottom line is that we can assume that they have a co-occurring substance use disorder. And we'll talk more about that as we go further. So some of the issues related to lack of people getting good mental health services and co-occurring disorders services in justice settings relate to the topic that we're addressing today, which is the fact that many get poor screening for mental disorders and or substance use disorders. When the screenings are provided, oftentimes it's a homemade, homegrown device. Instruments aren't used that are standardized and validated for justice populations. And oftentimes the staff don't have training in use of the instruments or in the specific areas, such as mental disorders or trauma, for example. Sometimes there's financial incentives to reduce classification levels of offenders who are mentally disordered, particularly if you have a contract for service setting, a private prison, for example. And then finally, there's issues related to the difficulty in actually identifying some of these disorders that are overlooked and that may not be readily things that offenders would like to talk about. There's a lot of shame and guilt associated with the mental disorders in general, but particularly with post-traumatic stress disorder, trauma history, and so forth. So we need to have targeted and ongoing screening in these areas. So what can we say about the importance of screening and assessment? I won't spend a lot of time on this slide, and I will tell you that I will skip through some of the other slides a little more quickly than others as we go forward today. But I think some of the general areas that are very important to note is that we talked about earlier, because of the high prevalence rates of both mental and substance use disorders, we need to have a universal screening for both sets of disorders in justice settings. We need to do this as early as possible to identify people, to triage them to appropriate settings, to provide the right dispositions at the time of sentencing, diversion services, pretrial services that might be available in the community, to identify services that are needed in jails and prisons and so forth, but to provide the right type of triage. As we mentioned before, people with undetected disorders very likely to cycle back to the system. Early detection is really critical for these individuals to prevent that from happening. And when it does happen, as all of us know, it's incredibly expensive to allow this rapid, uninterrupted cycling through the justice and other public health systems, such as emergency rooms and so forth, crisis stabilization units. So, of course, screening and assessment allows for good treatment planning and a triage, linking people to appropriate specialized services, such as co-occurring disorders treatment services, right, as well as other types of things. And finally, we know that when you have a systematic and well-thought-through system of assessment and screening, that we have better outcomes. And we have some good studies about this, that programs in different type of criminal justice settings that provide comprehensive assessment have, in fact, better outcomes. So as we move forward, I just wanted to share with you one thing that Sarah mentioned earlier, which is a monograph coming out that should be available this month. It's actually been quite a while in federal review, but now it will be available. And this is the third edition of this particular monograph that has been developed by the National Gain Center that's sponsored by SAMHSA. And I believe this monograph will be available on the SAMHSA website, but if you look, you'll find the National Game Center website within the SAMHSA website, and there should be a couple different portals or web links available for this particular monograph. I was the co-author on this, and I can share with you just some information. A lot of the topics that we're going to be addressing today are covered in this monograph, as well as specific information about the instruments that we'll be talking about. So, for example, as we talk about screening instruments, you'll be able to go to this monograph and find the web link that tells you how to access this. You'll have information about how does this instrument compare to other instruments in terms of its validity, reliability, use with criminal justice populations. How much does it cost? How much training is required, if there is any training? So it provides a fair amount of detail about the instruments and where you can get them. Also covers a range of the issues that we're going to be talking about today, such as how to conduct an accurate and comprehensive assessment for co-occurring disorders and so forth. So I would recommend you take a look at this if you have a chance, and perhaps Sarah and the staff at Council of State Governments can provide the web link to you when this comes out. So really our goal is to provide a blended screening and blended assessment for co-occurring disorders that covers both mental health and substance abuse issues. And I won't go through all of the items here, but these are the areas that we would hope to cover. And we'll look at these in a little bit more detail as we progress. So one thing I share with people when I talk about this issue is that we really need to have a systematic universal screening process for the different areas that we've talked about. And these are the major areas that I encourage people to look at. And there would be probably 4 of these that I think are just critically important. Mental disorders, substance use disorders, trauma and PTSD, and criminal risk. The other 2, suicide risk and motivation, are very important. Obviously, suicide risk is something that you would follow up on if you identified people that have depressive disorder or really any type of mental disorder. It would be a follow-up area for screening and assessment for suicide. Motivation, also important, and we know it's a predictor of treatment outcomes, but we also know that among offender populations that motivation is typically quite low, particularly as people are leveraged and coerced into treatment and are placed in jail or prison. We don't find high motivation levels for treatment up front, so that doesn't tend to be a factor in determining eligibility, does it, for our programs. We expect low motivation. We expect that to rise over time. And I think screening can be a useful process clinically for a number of reasons in providing a barometer of how motivation changes over time, and also can point us to some interventions as well, right? But I think for each of these areas, and particularly the 4 that I mentioned, the first 3 and the last item, you really should look at having a universal screening, I think, for your offender populations. And this would cover, if you're working across different points in the justice system, for example, the sequential intercepts, if you're familiar with that kind of concept, at different points such as jail, prison, courts, community-based interventions. Each of these points you would want to have a screening. So as somebody progresses through the justice system, you'd provide a similar type of screening at each different point. And of course, if the goal would be to share information as individuals progress through the system, in actuality, it's very difficult to accomplish in some cases. Use of screening for triage, we mentioned the importance of that earlier. So I won't spend a lot of time on this, but I think providing a systematic and standardized screening instrument and screening approach helps to provide within your justice teams, in your grant project and elsewhere, a common vocabulary for identifying what is criminal risk, what does that mean? What does that mean in terms of providing interventions? What do we have to do differently for somebody at high risk, medium, and low risk? Similarly, for high severity of mental health problems or for depression in particular, what does that mean? So it provides a way to communicate and I think more effectively share information about what you're going to do next and planning for both supervision plan, treatment plan, management plan as offenders are or managed in the system. Again, I think we avoid excluding people from our programs based on a serious mental illness, and I think you're the champions and leaders of this. I think all of you work with people with co-occurring disorders and are looking for ways to adapt your programs to be more capable of working with this population. We'll talk more about this third item, but really diagnosis isn't as important as level of adaptive functioning. How do people function in a treatment group or working in a drug court or in a residential treatment environment? What are the things that might impair their functioning? So it's not really a diagnosis that's as critical as the actual behaviors, right, and things that you can observe that would tell you whether or not an individual is going to have problems in a particular setting. The other item I think is really important, we don't want to use screening in place of a level of care assessment such as the ASAM assessment, right? So screening devices won't tell you whether somebody's a good candidate for residential versus an outpatient placement or detox only. It will tell you whether or not there's a need for further assessment, right? So it's basically a yes-no determination. So some programs make this mistake, though, and I've seen programs that do in very large states. Texas, for example, originally used a screening device several years ago to place people in residential care, and the consequences were pretty dramatic in terms of the amount of resources spent inappropriately for people that really needed a more intensive type of assessment process. And of course, the screening for mental health purposes allows you to then provide a more full clinical assessment for this population. We'll talk more about that. So some of the challenges, and if you bear with me, I won't spend a lot of time on this slide, but we have so many instruments out there, don't we? And it's really challenged. Which ones are the best? Which should I be using? And some states mandate a particular instrument. Some grant programs might mandate instruments like the GAIN that would be used. But some of the challenges and problems are that there are a lot of non-standardized instruments out there that don't have consistent scoring procedures, administrative techniques, lack of information about validity or reliability of the particular instrument, right? One thing that I've noticed is we don't have a lot of data about what's the difference between one instrument and another. So if you're picking a mental health screening instrument and I want to look at a couple different instruments out there, how do I know which one's better without spending hours and hours of work in the library and pulling up articles and so forth? And I think that's one advantage of having something like the Monograph from SAMHSA's GAIN Center that we talked about earlier, is that some of that information is that's kind of condensed, and you can compare instruments through use of those types of resources. The other challenge I'd point out is that there's direct-to-consumer marketing, isn't there, of many instruments. And I find that, you know, a lot of the commercially available instruments are actually poorer than the non-proprietary instruments, the public domain instruments, and we'll look at those in just a second. But one example is the SASI, which is one of the poorer instruments for looking at substance abuse, and it's one of the most expensive instruments. And there's certainly other examples of instruments like that that cost quite a bit of money in comparison to other public domain instruments that are free of charge. So we'll really focus on instruments today that are accessible and are not very expensive, that don't require a lot of training, at least for screening purposes. And I would mention the SAMHSA's GAIN Center Monograph that we talked about earlier does focus on the public domain non-proprietary instruments, but also covers other commonly used instruments. So again, we'll skip through this slide pretty quickly. How you select screening and assessment instruments. Again, important to look at how reliable are instruments if they're administered over again by the same person or by a different staff member. Do you get the same results? Are the instruments correlated with other similar instruments, examining the same types of areas? So, for example, if you administer a substance abuse screen, you would expect to get about the same rating or outcome score as with another substance abuse screening instrument. And so you could actually, there's comparative data for some of the instruments, many of the instruments, and looking at criterion or concurrent, they call it, concurrent validity for these instruments. So you want to see evidence of that. Certainly some of these other practical issues are very important, right? How much does it cost? How much time does it take to administer these instruments? And there can be quite a bit of variance in terms of the amount of time required to score, to administer instruments, as well as the cost. And then finally, I think this is overlooked, that many of the instruments haven't really been tested in criminal justice settings. So, and sometimes instruments that have been tested show pretty poor properties in justice settings. So I mentioned the SASE instrument. It actually shows poor properties for both adults and juveniles. For example, it has different types of validity outcomes for different racial ethnic groups in adults. So that's something you want to avoid in your populations. And so oftentimes there isn't information about use in justice settings, but if there is, we want to look carefully and see, are these instruments valid for use in justice settings? So before we look at instruments, I think one last thing I want to share with you is just, what about self-report data for offenders, okay? We know that offenders coming into our systems don't always tell the truth. I mean, they're characterized by some of the antisocial characteristics that include withholding information and kind of selfish, callous disregard for other people. And so it's anyone coming into a justice setting or in a treatment setting, there's a lot of contingencies about what would happen if you shared information. So what about self-report information? How accurate is it? We did a study in the last year and a half looking at this issue using a pretty large data set of 18,000 offenders, and also looked at the other literature out there. So briefly in passing, I just wanted to share this with you, that generally accuracy of self-report information from offenders is moderately good, not perfect. It's moderately good. We want to have collateral sources of information, right? Particularly for critical types of items, criminal justice history, substance abuse, et cetera. So we want other reliable informants who are living with the person, have lived with the person in the past, have contact with the person for drug use, but also for mental health issues as well, right? So we know relative to substance abuse, there's some of the interesting mediators of accuracy that help determine how accurate is the self-report information from offenders. We know, for example, the type of drug use that people report, there's a higher accuracy for reporting marijuana use than there is for heroin and cocaine use. You might predict that based on the severity of the substance and perhaps the consequences of sharing that information. We also know that there's differences across age, younger people, less reliable, some other differences as you see on the slide. And I did want to mention, in terms of treatment history, for people with substance abuse treatment history, the reliability and accuracy of the information self-reported is higher than that for people with a mental health history. So for people with co-occurring disorders, we actually have a particularly lower level of reliability of self-report information. So that means that we have to really go out there and get additional collateral source of information as much as possible. And oftentimes we don't have that. So we have to rely on the self-report information, right, up front, both for mental health, substance abuse, and other information. But we want to then continue our assessment process down the road as we can access other sources of collateral information. So let's look at screening instruments to start with, and I want to give you some examples that are described in more detail in the SAMHSA Gain Center monograph. And again, I'll focus on instruments that are primarily free of charge, public domain instruments. Here are 3 examples of evidence-based screening instruments for substance abuse. The Texas Christian University on the right-hand corner mirrors the DSM-5 new diagnostic formulation, and it's one of the few that's been adapted now for DSM-5. There are several other good evidence-based instruments. One is the top instrument, the ASSIST, which was developed by the World Health Organization, is also a very brief screener. And the simple screening instrument has been developed actually by SAMHSA and years ago, and has very good psychometric properties with offenders and other populations. There's others as well. The Addiction Severity Index, many of you are familiar with, has 2 different screeners for alcohol and drug abuse that are very valid and useful for offender populations. The GAIN simple screen instrument short screen is also a valid and useful instrument, although it does cost money. So these are all examples. Again, you have the slides that will be sent to you by the Council of State Governments. Let's look at mental health screening instruments. And there are two listed here, and I'd add one more actually. But the two that I have listed here, the Correctional Mental Health Screen and the Mental Health Screening Form 3, are both evidence-based screens. Again, very easy to administer, anywhere from 8 to 18 items that look at each of the major mental disorders in a very brief way to identify whether or not additional assessments needed. The other instrument I might add here is a brief jail mental health screen, which is an 8-item screen and has been validated in justice settings. So moving again pretty quickly through these instruments. Some people ask, well, what about co-occurring? Do we have an instrument for co-occurring disorders? And I think the answer here is yes, there are instruments out there that look at both sets of disorders. So if you look at the right side of the diagram here, the mini International Neuropsychiatric Interview has a brief screen that's 24 items that actually addresses both substance abuse and mental health issues, right? There are also other instruments like the GAIN that I mentioned earlier that covers both substance abuse and mental health. However, it's just as easy, I think, to combine an instrument on the mental health side with one from the substance abuse side. So if you look at the left side of this diagram, I've just presented examples of one of each, the Correctional Mental Health Screen and the TCU Drug Screen 5, which would take, I think, a combination of the two would take about 8 to 9 minutes probably to administer, maybe 10 minutes at the most. Very easy to score both of those. So I don't know that there really is a need to go to a full-bore co-occurring instrument when you can combine two that are standardized and have good evidence-based properties. So I mentioned earlier, it's really important to look at screening for trauma and post-traumatic stress disorder. Again, I'd recommend this to be a universal screen for your offender populations. So all offenders should be screened for trauma history. Why is that? The rates of trauma, as you see here, are incredibly high. When we started administering the Addiction Severity Index at the Hillsborough County Jail back in 1988, I was shocked and surprised to see that there was 50% of our male offenders were self-reporting a history of trauma. That just blew me away. And now we know, of course, many of the reasons why about exposure to violence, sexual abuse, types of different emotional, verbal abuse as well. But the rates of trauma among both females and males are quite high. And so it's not just female offenders that need a universal screening for trauma history. We'll look at that in just a minute in terms of what are some of the specific instruments. The good news is that there are a lot of instruments out there that don't cost money, that are non-proprietary. Also, there doesn't require a lot of training for initial screens, and the screening doesn't have to be provided by a licensed provider. It can be done by someone who hopefully has some knowledge of trauma and post-traumatic stress disorder, but more importantly, can refer people to services if there's a positive hit on that screen, which is the last point on this diagram, on the slide here. Other issues, we know that post-traumatic stress disorder, PTSD, and trauma are oftentimes overlooked, aren't they, in screening? And so why is that? Well, oftentimes we don't have training in that area, and so we don't provide screenings in areas that we don't have training. But oftentimes also if we ask questions to our offenders that we're seeing at intake in our programs or at our different settings, they're not going to volunteer that information. And so we have to have a structured approach, such as a standardized screening instrument, that can trigger this kind of screening approach. We know that oftentimes when you observe people that have trauma and post-traumatic stress disorder, you see things that can be explained by other mental disorders, such as depression, anxiety, borderline personality disorder, right? Maybe substance abuse as well. You might diagnose somebody as being in withdrawal from substance abuse and having depression, when in fact they have a history of post-traumatic stress disorder and trauma and are depressed for those reasons. And obviously there's overlap between these kinds of issues. But I think the outcome is that we don't have provided specialized treatment for trauma and post-traumatic stress disorders if we don't identify these things, right? The symptoms are masked, and what you get is people dropping out of your programs. and you get poor outcomes, whether it's a drug court, a residential program in a jail or prison, a community-based intensive outpatient program or day treatment program for probationers. You're getting people dropping out of these programs who have trauma and PTSD that haven't been identified and haven't been treated. So there really are major consequences for not doing a good job up front of screening and assessing. So what are the instruments that you might consider for trauma and post-traumatic stress disorder? I would suggest there's a number of different instruments for different purposes. And if you look at this diagram, I'd suggest there are 3 types of instruments here that gather different types of information. So at the top right of this diagram, you'll see 2 examples of instruments that look at the history of trauma events. The trauma history screen, the life stressor checklist, right? Or the life events checklist. There's actually 3 there. And what these instruments do is give you a set of events that have happened for a particular individual that may have caused trauma in the past, and that then you can follow up on it in a little more detail. And I think we all know our offenders have been exposed to multiple trauma events. So many people have had a history of sexual abuse. It may not be just once, it may be more than once. Similarly, victims of violence, other types of violence, physical violence, emotional violence, as well as observing other violence activities in their community and their household. So it's really important to take a history of the types of events that may have caused the trauma symptoms. So if you look, the second type of screening instruments here are really trauma screens, and that would look at the symptoms of PTSD and trauma. So down at the right-hand corner, lower corner, you'll see the primary care PTSD screen and the PTSD checklist for DSM-5 or the PCL-5. And these are, again, evidence-based instruments that don't require a lot of time to administer that actually get at the DSM-5 criteria for post-traumatic stress disorder. Very quick to administer. The PTSD checklist for DSM-5 is a 20-item screen. Very quick to administer, validated, used, and developed actually within the VA system, now used in civilian populations throughout the country. The third type of instrument here would be diagnostic instruments. And so you'd see at the left-hand top corner post-traumatic symptom scales. One example of that, you also have the clinician-administered PTSD scale for DSM-5 or the CAPS-5 that go into more detail about getting an ironclad diagnosis of post-traumatic stress disorder. And these would be for people that you would need some further clinical assessment if they are determined to have post-traumatic stress disorder. And this type of diagnosis and more full-blown assessment would then point to, again, level of care that would be needed in specialized treatment services for trauma in this case. So one other area of screening and assessment that we'll touch on is a screening for criminal risk, and you probably received, I'm guessing, some additional training in this area. So I won't spend much time at all today talking about that, and we'll skip pretty quickly on to assessment of co-occurring disorders. But before we do, I think it's just useful to note that screening for criminal risk, I believe, is also should be included as a universal type of screen for offenders. And the goal here, again, is to select offenders that have a higher risk profile and also high needs for treatment, high needs in different areas that are specifically related to criminal recidivism. And those are things like employment, substance abuse, antisocial attitudes, family support, education level, things like that, that all independently predict the risk for arrest and recidivism. So again, the important point is that we want to focus and identify high-risk populations for placement in services, in behavioral health services for co-occurring disorders, for example. Just to note that we also want to identify people at low risk so we don't place them in high-intensive services. They are better off in lower intensity services. And we know that mixing high and low risk groups is problematic and actually can lead to adverse outcomes. So what about criminal risk assessment and screening? Well, generally these look at a couple areas. One are static factors, which remain unchanged, and typically these are criminal history factors, such as age at first arrest, number of prior felonies, right? number of prior convictions. Then you have a set of other things that are changeable or dynamic factors. And these I mentioned earlier are again, the areas of high criminogenic need that are the focus of our case plans and our treatment plans that actually we can intervene with and make a change and make a difference in terms of risk for recidivism. So again, these are areas like substance abuse, criminal thinking and attitudes, criminal peer networks, employment, education, family support, leisure skills, leisure activities, and so forth. Very important to look at. So just in a nutshell, what are some of the examples of instruments that are out there? And this is just a snapshot, folks, of the type of instruments. And again, it's kind of overwhelming if you look at the range of risk assessment instruments and you say, what can I use? I would say to start off with, there are two types of these instruments. One is a screen for risk, and then there's an assessment for risk, and we'll talk a little bit about these. But briefly, the risk screen would be used in many jurisdictions to weed out and identify people at low risk that don't belong in intensive services, and conversely to identify those that are high risk that are really your target population, moderate to high risk for recidivism. The more in-depth assessment for risk then would look at the risk factors that we talked about earlier, the dynamic risk factors in more detail to provide a profile of an individual offender who's been identified as being high risk or moderate risk, and looking at which areas do you need to target for intervention for these dynamic risk factors that change over time that you can intervene with in your programs. And so, of course, as you know, the more of these independent risk factors for recidivism that you can target in your programs, the better outcomes you have among your offenders with co-occurring disorders in terms of rearrest. So without spending a lot of time, there are a number of different instruments represented here. The Ohio Risk Assessment System, for example, is a non-proprietary set of instruments free of charge, developed by University of Cincinnati in concert with the state of Ohio. There are 3 different screens included in the ORAS system. Another example you might be familiar with is the Risk and Needs Triage, the RANT instrument, which was developed specifically for drug courts, but is used in other settings as well. And there's many other instruments here as well. I would recommend there is many other resources that would be able to provide you more information about these instruments. And here's one example of a monograph that was developed that provides some kind of comparative analyses of some of the risk assessment instruments that I'd encourage you to take a look at. Again, this is free of charge, downloadable from the internet. So what can we say about assessment of co-occurring disorders among offenders as we transition? And again, I won't spend as much time talking about specific instruments here because I think we don't have as many specific instruments for co-occurring disorders. It's kind of mix and match, but we'll get to that in just a minute. But I do want to share with you some general considerations about features that influence the screening and assessment process, but also are the focus of assessment, treatment, and supervision of offenders that have co-occurring disorders. So here are 3 of the hallmark features, I believe, clinically, that distinguish individuals that have co-occurring disorders in the justice system that have to be addressed in our assessment process that also affect the way that we conduct assessments as well, right? So cognitive impairment, concentration and attention difficulties, problems with verbal memory or encoding information that's shared verbally. And then finally, another area of cognitive impairment would be related to what we call executive functions or planning abilities, right? So people with co-occurring disorders have impairment in the frontal lobe capacities of the brain and that affect planning and how you deal with consequences of behaviors and planning for things that might occur the next day, avoiding things that have been problematic in the past. And so these are all things that we program into our treatment approaches, but we also take these into consideration during the assessment process. For example, for people with limited concentration and attention abilities, we want to limit the amount of time in one setting in one sitting, excuse me, that we provide for assessment. So we don't have a 2-hour or 2.5-hour assessment process for somebody with co-occurring disorders in the justice system. We might provide an hour, break it up, and come back after there's a break over time. And so we also provide treatment groups, right, that are shorter than we would provide for individuals that have substance use disorders, for example. So instead of an hour and a half or a 2-hour group, I've seen those in the past, but typically a 90-minute group, you wouldn't do that for somebody with co-occurring disorders that has a major mental disorder, bipolar or a psychotic disorder, for example, that really doesn't have the ability to concentrate and provide attention over a period of time. So we would shorten our treatment groups. So implications not only for the format, but also for the focus of our treatment interventions and for assessment as well. So some of the other areas that we would want to look at in terms of assessment, reduced motivation. We know this is, again, a character, kind of a generalization for people that have co-occurring disorders. A hallmark of this population is lower motivation, people that haven't had a history of success, good outcomes in different programs or activities in their lives. And so the interventions that we provide, as well as the assessment that we provide, focuses on that as well. And then finally, impairment in social functioning, interpersonal skills, dealing with conflict, problem-solving skills, lack of assertiveness, poor communication skills. All of these are important focal areas for assessment and also are important for us to consider in how we provide assessment interpersonally with individuals, not challenging them or confronting them right up front until we develop a relationship at least, but providing more support, looking at positive areas of strengths, for example, in the assessment process. So just some considerations here for assessment before we move further. So other things to keep in mind for assessment of co-occurring disorders in the justice system, we know that any drug of abuse, as well as legal drugs, alcohol, for example, can mimic major mental disorders. There's not a single mental disorder that can't be mimicked by active use of substances. So this is a challenge for us, isn't it? Because we have people that come into our settings and have been actively using recently, and we don't exactly know whether we have depression or whether it's a residual effect of detoxification over time. We don't know if we have paranoia that's part of a psychotic disorder, or if it's something that's related to methamphetamine or cocaine use, for example, right? So some of the strategies that we use to address these issues and challenges are using other collateral sources of information, such as drug testing, to verify abstinence. We also want to use a longitudinal approach, right? So we mentioned before, we don't just gather information up front. We mentioned before this accuracy of self-report may be compromised among people with co-occurring disorders. But we also know that people aren't great historians when they're actively using drugs and alcohol or have recent use. So we want to look over time at the longitudinal history of mental health and substance abuse issues to look at the symptom interaction. So, for example, we want to look at periods of abstinence, whether they're enforced abstinence, such as residential treatment or a period of incarceration in jail, and ask about whether or not there were active mental health symptoms at that point in time, so we could begin to disaggregate and figure out if it was the substances that may be causing the mental disorders, or in fact, you have a bona fide mental disorder that's going to exist that needs to be addressed and treated. And of course, we'll find that out if you can keep people in an environment in which you have enforced abstinence. But right up front, it's difficult to determine that sometimes. We want to compile our diagnostic impressions for that reason over a period of time as well. And so many of our diagnostic impressions will be provisional, right? Because we don't know if they're substance-induced mental disorders or if they're bona fide mental disorders that have existed for a period of time. And then we want to repeat assessment over time. By the way, not just for the co-occurring mental disorders and substance use disorders, but also for risk assessment, right? Because criminal risk changes over time as individuals are exposed to interventions that you provide for education, employment, substance abuse, criminal thinking, those types of things. So we want to provide assessment over time for both the co-occurring mental and substance use disorders, but also for criminal risk. Just some other things very briefly in passing. We want to have a high index of suspicion for mental disorders, right, because of the high rates in criminal justice settings. Because of some of the clinical features that we talked about a few minutes ago, we want to use a non-judgmental approach, right, in addressing, interviewing people at the point of intake. They come into reception at prison or they're at booking in jail. If you're seeing them in a setting for community supervision, where they're in treatment for the first time or second, third, fourth time, we want to use a non-judgmental approach, and also try to use some motivational interviewing approaches where we're listening and summarizing and paraphrasing and not confronting people with the fact you have a substance use disorder, you're an addict, using labeling, stigmatizing kinds of language. We want to strategically sequence our questions and the interviews in a way that provides an opportunity to engage with the offender and to develop a relationship so that there's more trust. You have more of a chance to get accurate information over the course of the interview and assessment process. So in this case, one example, quick example, is you'd gather substance abuse information before you gather mental health information or information about trauma history, right? Because substance abuse information is less stigmatized, and you're more likely to be able to get accurate information and to establish some rapport in gathering that information. Even before substance abuse information, you'd probably even talk about a past history of employment. Why are you here in the treatment program? Tell me about your family, where you grew up, job history, skills that you have, those kinds of things that are non-stigmatizing that would help engage the offender in a discussion with you. And then, of course, we talked about the importance of collateral information again. Again, family members, could be correctional officers who have seen the person in a jail setting, case workers, case managers, people that live in the halfway house with the individual. So what are some of the areas for the assessment itself? And again, you have this in your slides, and I'm not going to spend a huge amount of detail in going through this, but of course, this information is quite a bit more detailed, isn't it, than what you would gather in the screening process that we detailed earlier. So here you're really looking at the severity of the disorders, not just whether they have a disorder, but the diagnosis, the type of mental disorder they have, how severe is it. The same holds true for substance use disorders. Again, the pattern of how the disorders interact over time. Do you get, are there certain kind of characteristics, patterns that when somebody uses alcohol, they're violent, and when they use particular drugs and alcohol together, they tend to have paranoid thoughts and unusual belief systems that come out. So gathering that information is quite important. We, of course, want to look at aspects of antisocial behavior and attitudes. And there are some specific instruments that get at this. So Texas Christian University, for example, has a criminal thinking scale that looks at some of these areas as well. Motivation for treatment we talked about. And this would be more detailed than just give me a 1 to 10 scale of how motivated you are right now for treatment, right? You go into some detail about what's in it for you. What would you like to work for? What can we provide that would be a benefit for you? And it may not be abstinence, that there is a primary goal for an individual coming into treatment, right? It might be getting stable housing, supported housing. It might be regaining custody of their kids, some things that we would see as that would take time to accomplish, but yet are very important that we can use as kind of leverage to get people involved in abstinence-oriented programs and working on mental health issues as well. Other areas here as well that you see in the assessment process. And this would, again, covers the areas that would be addressed in the assessment in more detail that aren't covered in the screening. Now, I just want to share with you one thing here. If you look at the areas of functional impairment, this is interesting, isn't it? This covers some of the clinical issues that we talked about earlier that are hallmarks of people that have co-occurring disorders both in and out of the justice system, really. But what you'll notice is these are areas that we don't have good instruments. We don't have a standardized instrument, really, to talk about communication skills, right? We do have for reading skills, so that would be an exception. But look at capacity to handle stress. That would be an important factor, wouldn't it, in terms of eligibility for a drug court program, for example. ability to maintain eye contact and to have a conversation and not go into an internal dialogue that involves paranoia and the FBI or CIA conspiring with the prosecutor and the judge in the drug court example. How well are they able to participate in group interventions? So again, we don't have standardized instruments that we would administer for these purposes, but these are things that we can observe and need to be part of the assessment process, whether or not we have a good standardized instrument. And so these need to be built in a structured way in the gathering of information during the assessment for co-occurring disorders. And then finally, as we talked about earlier, very useful to have a level of care assessment. And you're familiar with the ASAM criteria, patient placement criteria formerly, but the ASAM criteria looking at what level of care is needed. So how do you triage somebody into different levels of care that may or may not be available in your setting? So that's a challenge. In some settings, we don't have more than just an outpatient program or a residential program, as it might be. But the ASAM or some of the other locus would be another example of instruments that look at this in more detail. So I will share with you a couple examples of instruments that are out there that you can use that cover substance abuse and mental health issues, but aren't perfect. I would say each of these instruments is somewhat imperfect in that they don't address each of the areas that we've talked about in sufficient detail. And I won't cover these in detail. A lot of you are familiar with the Addiction Severity Index. It's probably the most commonly administered instrument of any type that's provided throughout the world. It's been around for over 20 years. The GAIN, a second instrument there, many people are familiar with that. And the GAIN is an example of instruments where there's a family of different instruments that are available, including screening instruments as well as assessment instruments. And in this case, the GAIN, as well as the third set of instruments there, the Texas Christian University instruments, both of the GAIN and the Texas Christian University instruments have a family of different instruments that include screeners as well as brief assessments and then more comprehensive assessment instruments. So I would encourage you to take a look at these. The GAIN is a proprietary instrument that requires a cost up front to train staff in use of the GAIN, whereas the Texas Christian University instruments, for example, is non-proprietary, and you can actually download those from the internet free of charge. There are a range of other standardized instruments that we identify in the monograph that I mentioned earlier that's going to be published by the SAMHSA. And these tend to focus on different areas. The one that focuses specifically on co-occurring disorders is very lengthy. It's quite cumbersome, but I do want to mention it. It's here on the left-hand side, the IDATIS. And this, you'll see, is structured for the DSM-4, and I don't believe there's a DSM-5 version of that available. The mini instrument we talked about earlier, and again, there is an assessment version of the mini that provides 120 items that look at a diagnostic impression for both mental and substance use disorders. It's pretty quick in terms of an assessment instrument for co-occurring disorders. It takes about 20 minutes to administer this version. Again, there's other more lengthy versions of the mini. The SCID is on the right-hand side here of the diagram, and this would be kind of the gold standard for diagnosing mental and substance use disorders. And there are modules that would look at specifically a particular mental disorder or substance use disorders, as the case may be. So you can, to administer the entire thing would take a couple of hours. To administer certain modules might be much shorter than that, would be much shorter than that. And then the top instrument is an objective mental health instrument that's used quite commonly in forensic settings, other settings, to look at mental health disorders. So in wrapping up, before we get to our question and answer session, just very briefly, the purpose of gathering this type of information, which is including both screens and assessment information, is to provide, as we started out with in the webinar today, to look at triage, right? To place people in appropriate services depending on their level of need and level of risk for criminal recidivism. So we would place people in treatment and supervision tracks, ideally, based on the findings from our assessment process. And it might be a specialized, hopefully a specialized residential co-occurring or an outpatient co-occurring program that you would have available. If not a separate freestanding program, it might be a track that's existing within a mental health or substance use program. For example, it might be a co-occurring track within a existing drug court program, right, that acknowledges that many offenders coming into the drug court have co-occurring disorders, and that thus we need several groups every week that focus on co-occurring. We also need medication consults with trained physicians in addictionology that focus on co-occurring disorders. So you might have a track embedded within an existing program. And something I think that we're going to see increasingly is specialized supervision tracks that also address the criminogenic needs that we talked about earlier, that also address co-occurring disorders. And you have, in fact, specialized supervision teams around the country now working in probation and parole that focus on mental health and serious mental illness. Not so much specialized teams for co-occurring disorders, although I would argue that teams that focus on mental illness really are co-occurring teams, aren't they? Because people with a major mental disorder typically have a co-occurring substance use disorder. So wrapping up, just in summary, a lot of challenges, right, in screening and assessment for these disorders in the justice system. We want to have a universal screen across multiple domains for different areas that we talked about today. And instead of just focusing on diagnosis, we want to look at functional impairment and things that we can observe that aren't always available to us through results of a standardized instrument, but it might be, reactions to stress or ability to handle themselves in a group treatment setting, communication skills, et cetera, lack of overt and impairing major mental symptoms, acute mental health symptoms. And then finally, there's the good news. We have lots of evidence-based instruments available for each of these types of disorders, including co-occurring disorders. I encourage you to learn more about those and to gather information about which might be most appropriate in your setting. So let me finish here, and I think we're going to move to our question and answer period.
Thank you so much, Dr. Peters, for that fantastic presentation. And we will, a reminder again that you can actually enter questions through the chat box, but we're also going to open up the lines for questions. So we have a few initial questions that came in that we will address, and then from there we'll open up the lines. So to begin with, so Dr. Peters, do you have any recommendations for developing the